Assalamu alaikum wa rahmatullah. This is Dr. Khalil Al-Salem speaking. Thank you so much for taking the time to see our lecture. This is a lecture upon a kind request from Dr. Susan Rattal in Al-Kindi University. في أحد الأيام كان أم العبد وأبو العبد جالسين مع بعضهم البعض، فقالت أم العبد: يا ريت ربنا يرزقنا الطفل حلو وجميل. وأبو العبد قال لك: يلا عليهم، أنا جاهز. ربنا رزقهم بعلي. فسبحان Allah, the creation of Ali didn't come all of a sudden. It came through stages. So the first stage was fertilization, where a zygote is formed by the fusion of both an ovum and a sperm. After that, the cell starts to divide. We have the 2-cell stage, 4-cell stage, 8-cell stage, and then we have the moriola stage. After that, the moriola will leach itself to the endometrium to start to form the embryo. At day 16, a small embryonal disc can be recognized, and this is formed of 2 cell layers, epiblast and the hypoblast. The epiblast will form the future ectoderm, and the hypoblast will form the endoderm. And these are actually sandwiched between 2 cavities. We have the amniotic cavity and the yolk sac. Afterwards, around 17 days, a small structure will start to drill between the 2 layers, the hypoblast and the epiblast. This is called the notochord. The notochord will cause activation of both epiblast and the hypoblast to form the endoderm, mesoderm, and ectoderm. And the ectoderm will start also to differentiate into surface ectoderm and neuroectoderm as well. Surface ectoderm overlying the notochord will start to groove in to form the neuroectoderm. And this will start as the neural groove, which will close centrally, and then it will zip cranially before caudally by 2 days. So at 26 days, the neural tube is closed cranially, and at 28 days, it will close caudally. Defect of closure will form neural tubular defect. So at day 23, small to primordial eyes will start to form. This is called the optic pit. The optic pit at the cranial part of the neural tube will form an optic vesicle. This will further invaginate to form an optic cup. As the optic cup is invaginating, it will activate the overlying surface ectoderm, forming a lens pit and a lens vesicle, which will be engulfed inside the primordial cup or the optic cup. Now, the optic cup has 2 layers. We have an outer layer and an inner layer. The outer layer will form the retinal pigment epithelium, while the outer layer will form the neurosensory retina. This is a very important piece of information, as it will give you insight on the pathology of retinal detachment. Just a quick insight on the lens embryology. The lens placode will be engulfed inside the optic cup, and it will start to get its blood supply from the anterior and posterior tunicovascular lentis. These blood vessels will regress with time, and they will disappear as the lens is deemed to become acellular. It will become just a bag filled with proteins, and it retains its cytoskeleton along with a capsule which is covering up these proteins. The lens has 3 proteins. These are called the alpha crystalline and beta gamma crystallins, and these are heat shock proteins or chaperones. They maintain and preserve the cytoskeleton, and they maintain the protein, preventing denaturation of the protein, as we will see in the upcoming lecture. As we have taken the basic embryology, now we will talk about anatomy of the anterior segment, cornea and lens, sclera, anatomy of the uvea, and finally anatomy of the retina. The cornea and the sclera forms the fibrous layer of the eye. followed by the vascular layer, which is the ciliary body along with the choroid. And finally, we have the neural layer, which is the retina, along with the endothelium covering the ciliary body. The transparent part of the fibrous layer is called the cornea. It has a power of 43 to 44 diopters and a horizontal diameter of around 11.5 to 12 millimeter. The vertical diameter is less than the horizontal by 1 millimeter. The power of the cornea is more in the center of the cornea and less in the peripheral. This is called the aspheric cornea, and it has the advantage of decreasing the optical aberrations. Histologically, the cornea is formed of 5 layers. We have the epithelium, which is the only regenerative layer, followed by the Bowman's layer, which is the acellular layer of the stroma. The stroma, which has keratocytes and collagen. And finally, we have the Descemet's membrane, which is the basement membrane of the endothelium. And finally, we have the endothelial cells. These endothelial cells play an important role in maintaining the compactness of the stroma. The histology of the cornea starts from the epithelium. The epithelium is around 4 to 6 layer thickness. The basement layer, which is the deepest layer, is the only regenerative layer. And then these cells, they become more and more flattened as they go to the surface. These cells are bound together by tight junctions so that they do not allow fluid from the tear film to enter into the stroma. This will help optimal hydration of the stroma, and it will prevent stromal edema. Another important thing is that we have a basement membrane. This basement membrane is only found at the basal layer. At the basal layer, the deepest layer. Two clinical applications of what we learned. The first, for example, in the case of a corneal abrasion, the epithelium regenerates very fast within the first week, and usually it closes the defect, but full thickness doesn't go there until 5 to 6 weeks, until full thickness of the epithelium goes back to normal. Another application is that the tear film is the only and most important refractive surface of the eye. If you don't have a stable tear film, unfortunately, this will cause overscattering of light because the epithelium or the surface of the epithelium is very irregular. So if there is no tear film, adequate tear film to close or let's say homogenize the surface of the eye, the patient will start to feel that there is blurring of vision along with the redness and grittiness that happens with dryness of the eye. The second layer is the stroma. The stroma consists of around 85% of the corneal thickness. It has two important layers. We have the Bowman's layer, which is the acellular part of the stroma, and we have the cellular part, which is the stroma proper, that contains keratocytes and collagen type 1. The collagen fibers are always parallel to each other, and they are compact in a way in order to minimize scattering of light. If there is haphazard deposition of the collagen, or there is corneal edema, which is fluid between the corneal bands, or let's say the collagen bands, then you'll have a lot of scattering of light, and this will cause the cornea to become opaque. Nerve bundles supply the stroma from the trigeminal nerve. Usually it comes from the periphery at 9 and 3 o'clock, and then it forms circles. We have deep nerval arcs and then superficial nerval arcs, which are found in the stroma of the cornea. The endothelium is monocellular layer of cuboidal cells that are bound together by tight junctions. These cells are very important and play a role in the optimal hydration of the cornea. They actively pump water out of the stroma to the inside of the eye or the anterior chamber. and any decrease in the cell count in these cells will jeopardize this function, and it will cause corneal edema or fluid inside the stroma, which will cause opacity of the cornea. These cells are attached to the stroma by the basement membrane called Descemet's membrane. The endothelial count is highest at birth, and it should be maintained between 3,000 to 4,000 cells per millimeter square. But it will decrease with time as the patient age, and there will be cell loss. If the cell count goes below 1,500 cells per millimeter square, then the cornea will start to become edematous. This information is very important, especially before doing corneal grafts. A corneal graft should have at least 3,000 cells per millimeter square before implanting it in a patient. Otherwise, the half-life of that corneal graft will be low. It is very important to note that endothelial cells do not regenerate. They respond to stress by hypertrophy only. And the size of the cell increase and the function also increase till a certain limit. Afterwards, they decompensate. Now we will be talking about aqueous outflow. The aqueous is produced by the processes of the ciliary body, specifically the non-pigmented epithelial cells. Afterwards, this will travel to the posterior chamber, through the pupil to the anterior chamber, and from there it will be filtered to the trabecular meshwork, out to the episcleral veins. The aqueous flow has many important functions. The first one, which is maintaining the dimensions of the eye by maintaining adequate intraocular pressure, which is between 9 and 21 millimeter mercury. The other important function is nourishment to the endothelial cells and the lens, because these structures are avascular. They need nourishment from the aqueous, which bathes the cells of the cornea and the lens at the same time. There are two important pathways through which the aqueous filters out of the eye. The first one, which is the conventional pathway, this is called the trabecular meshwork, and the other one, which is the unconventional pathway or the uveoscleral pathway. The conventional pathway of filtration is called the trabecular meshwork. This has the three important layers: juxtacanalicular, which gives the largest resistance, followed by corneoscleral, and finally the uveal part of the trabecular meshwork. And from there, the aqueous will be filtered into a circular canal. It's called the Schlimm's canal. From there, small collector channels will take the aqueous, and this will be filtered into the episcleral veins. The lens is the second refractive surface of the eye. It has around 17 to 20 dioptric power, and it is suspended by the lens zonules, and these lens zonules attach the lens to the ciliary body. The lens has the ability to accommodate whenever the patient is looking at a near object. The ciliary body will contract, and this will cause a slackening of the zonules, and the anteroposterior diameter of the lens will increase. By that, the power of the lens will increase, and this will allow the light to be focused on the retina. Accommodation is age dependent. We are all born with a high accommodative reserve, which can reach up to 20 diopters. However, this decreases with age. So at 20 years, you have around 10 diopters, and at 40 years, you have 6 diopters, and at 60 years, you have 0 diopters. It is thought that the rigidity of the lens accounts for the loss of accommodation, and it is not as was thought in the previous days that the ciliary body might be compromised due to the aging process. The lens is devoid of blood vessels, and it has an oblate shape, and it has lost all its cells. What you see is just proteins called crystallins, and the fibers which constitute the cytoskeleton of the lens. The lens has three important parts. We have a nucleus in the center of the lens, and then you have a cortex, and this is encapsulated via a capsule. The capsule is formed of elastin. The capsule is very important as it separates the contents of the lens from the eye. The capsule is thickest anteriorly and it is thinnest posteriorly. The lens mass increases with age. At birth, it's around 65 milligrams. However, there is a large jump in the first year of life to reach around 125 milligrams. And then it continues to add more fibers as the patient age until death. So at around 90 years of age, the lens can reach a mass of 260 milligrams. New fibers are added from the equatorial region. This explains how biologically you can know the age of the person from the lens mass. The choroid is the vascular layer of the eye. It is composed of three parts. We have the small vessel layer, large vessel layer, and the choriocapillaris capillaris. The function of the choroid is to nourish the outer one-third of the eye. It has other important functions that pamper and help the photoreceptor to function normally. One of them is heat regulation. You know, the photoreceptors are subjected to high temperatures. This is because the light which hits the retina, part of it is converted into heat. And it's the choroid function that has the melanin to absorb most of the heat. And because of the high flow circulation, which is found in the choroid, most of the heat will be dissipated. The blood supply of the choroid comes from the long and short posterior ciliary arteries. These are blood vessels that originate from the ophthalmic artery. The retina is the nervous layer of the eye. It has the ability to change electromagnetic waves, which is light, into electricity, meaningful electricity that can be interpreted by the brain. The retina has three important functional layers. The first layer, which is the photoreceptors. These are the rods and cones, followed by the first order neuron, or what we call the bipolar cells. The bipolar cells connect electricity from the photoreceptors to the ganglion cells, which are the second order neurons. The photoreceptors has important two types. We have the rods and the cones. Collectively, the rods and cones are around 125 million cells. So we have 5 million cones and we have 120 million rods. So the cones are found in the center of the retina, an area called the fovea. This is the most important part of the retina that can see colors. It has the best visual acuity, and it has the ability to see static images, unmoving images. Unlike the rods, which are found at the periphery of the retina, it has the ability to detect movement, and it doesn't see colors. It only appreciates white and black images. The photoreceptors receive their blood supply from the choroid. The choroid filters most of the blood, or let's say most of the contents in the blood, and then it is the job of the retinal pigment epithelium, these are around 6 million cells, that filter a specific concentration of materials that are used by the photoreceptors. For example, photoreceptors need high concentration of vitamin A. They are very sensitive to toxic materials, for example, penicillin, other materials like lipids and proteins. That's why it's very important to selectively allow specific materials to enter into the matrix that bath those cells. And on the other hand, waste products should be dealt with. Every morning, 100 disc is shed from every photoreceptor into the matrix of the retina. This is taken by and dealt with by the retinal pigment epithelium, which recycle up all the good materials back into the photoreceptor and take the waste products out to the circulation. At the fovea, there is a one-to-one connection, which means one photoreceptor will convey to one bipolar cell and one bipolar cell will connect to one ganglion cell. However, in the periphery, connection is dealt with by something called temporal summation, means that many photoreceptors, many rods, will convey a signal to one bipolar cell, and many bipolar cells will convey the signal to one ganglion cell. The ganglion cells are the second-order neurons. They collect all the information which comes from the retina, and after that their axons will exit the cells and they will converge all to form the optic nerve. And the optic nerve is called the blind spot of the retina because there is no visual field at that area, or no, let's say, photoreceptors at that area. So this area is blind. But most of us do not appreciate it because we have two eyes, and one visual field will obscure the other's eye blind spot. That's why we don't see it.